Hello everyone, this video is regarding phacoemulsification in hard cataract. I have switched off the light retroillumination to see the grade of the hardness. See, it's nearly black or grade 4. So we'll especially see in the end what is scaffold technique, and as this is high myope and vitrectomised eye, will perform flip and chop technique, which I routinely do in all my cataracts. So just to show that flip and chop is a very useful technique in such kind of hard cataracts also. And this is a fairly hard cataract and very dense cataract. The main issue in this is as this is high myope and vitrectomised eye, so in the end when we are taking out the last pieces, there are very high chances that phaco tip can touch the posterior capsule and might break it. So we are starting this case as a routine case. So we are doing the initial steps very routine manner. We are performing the capsular axis continuous with the help of a cystotome. You may do this step with the help of a rhexis forceps. I find it easy and comfortable. Maybe I am used to it to perform it with rhexis needle cystotome. So globe stabilizer and main port with the help of 2.8 millimeter keratome, adequate size rhexis to cover the edges of the optic of 6 millimeter or 5.5 millimeter IOL, and all the initial steps are done very routinely. So just inject the balanced salt solution from one side, and here you see the nucleus is prolapsed. The one pole of the this lens is prolapsed out of the capsular bag, and now it is standing vertically in the bag. So this is the key of flip and chop. So just embed the probe into the core of the nucleus at the one edge of the nucleus, and bring the chopper from the other end of the nucleus. Bring the two instruments towards each other and crush the nucleus in between the two instruments. In this way we can achieve a chop, and we can divide the nucleus into the two pieces. So the posterior fibers of the lens are very thick and leathery, so it is taking little bit of struggle and effort to divide them into the two. So in such cases we need to have lot of patience. So here you will see that I will keep separating chopping these nuclear fragments, nuclear pieces very patiently, no hurry, and minimal use of phaco power. So till now we have used almost negligible amount of phaco power. The main role is of maneuvers which you are performing to divide this nucleus, which is very hard. So again, embed the phaco tip into the core and chopper around the nucleus and bring them together. One more fragment. So in similar manner, just keep rotating the nucleus and try to fragment the nucleus into multiple pieces. So just have patience and keep doing this till you get multiple fragments which are totally detached from each other, and in the end, so you can easily phacoemulsify these nuclear fragments one by one. So here we can see the fragments are still attached to each other and not separated properly. So we can find them attached to each other in the center. These fibers are very thick and leathery. So as you can see, there is one loose fragment, so just take out this fragment so that we can find some place to do phacoemulsification. So it will make up some space. So one fragment is out, there is little bit of space into the capsular bag to do further phacoemulsification. Keep injecting viscoelastic to coat the endothelium by taking breaks. Don't come out of the eye again and again from the main port. Keep the phaco handpiece inside the eye. Another fragment, another nuclear piece we are emulsifying. Keep rotating, keep separating. This is the key. Have patience. So one more piece, one more fragment. So one by one, all of these can be taken out easily. Just is the matter of patience, and keep your phaco tip occluded all the time. These nuclear pieces will automatically get loosen up, and one by one they come out easily. Don't be in hurry, as till you can see the posterior capsule, this is a blind procedure, so you have to be very safe and at the pupillary plane, not too much close to the endothelium. So as you can see, last two fragments are remaining. So here is the key. The posterior capsule is trying to come upside, as there is no support of the vitreous in this eye. So here I decided that I will not take out these two fragments with the phaco probe. So I decided to do the cortical removal with the irrigation aspiration, coaxial irrigation aspiration, and I have polished it, taken out the cortex from all the quadrants, and these two fragments are left as it is. I'm not because I'm afraid that taking these two fragments out with phaco probe may cause post occlusion surge, and it can hit the posterior capsule and it can break the posterior capsule, and it will complicate the case. So single piece lens is injected, leading haptic directly into the bag, trailing haptic is dialed into the bag. The two nuclear fragments are still lying in the anterior chamber above the iris. Now lens is implanted into the bag. So try to keep the IOL in the primary position. Here I am doing the limbal relaxing incision, paired limbal relaxing incisions. The more it will be towards the center, and more the thickness of these incisions, more will be the neutralization of astigmatism. So I'm on the other side, I will pair it. So this is called limbal pairing to neutralize the astigmatism. Now with the phaco handpiece, I will emulsify these two nuclear fragments very easily and without any fear of breaking posterior capsule, as IOL is a scaffold. So this is the scaffold technique which may be very useful in such cases. So that these two fragments are removed very safely, and here we have finished the case. Last fragment is coming out. So here we have finished the case. Visco removal is done and side ports are hydrated. So this is the end of the case. Hope you must have liked the video, and thanks for watching. I appreciate your patience.